this morning, I take this opportunity to welcome our eminent speakers and delegates on the occasion of fifth series of IAS Society. As the series is progressing, I'm sure you must be finding it to be more elaborative, informative, and very, very interesting. Our privilege to have our eminent speakers for today's webinar. Let me take this privilege to welcome Dr. Simab Sheikh, Dr. Filippo, and Dr. Srinivas. And our today's moderator is Dr. Vikas Agrawal. With this, I hand over the session to Dr. Vikas Agrawal. Thank you very much.
Hi, very good morning to all of you. And today's session is going to be really interesting because we all know that soft palate is the reason for obstructive sleep apnea in more than 90-95% of the cases. And in 75% of the cases, it's alone is the cause of the sleep apnea, where base tongue, epiglottis, etc. are not included. So what is to be done as a surgical procedure in the soft palate is the topic of discussion today. From minimally invasive to maximally invasive, we have Simab Sheikh, Dr. Simab Sheikh from Pune, who was the founder president of our association and who has done extensive work on the minimally invasive procedures on the soft palate. He will be discussing on the minimally invasive surgery for the soft palate. Then we have our dear friend, Dr. Filippo Montevecchi from Forlì, Italy, who has been coming to India for a long time now. So he's a great friend of ours, and they have pioneered one of the techniques of barbed suture pharyngoplasty. So Filippo is going to talk on the technique of barbed suture pharyngoplasty, in which he'll explain how we can take care of the soft palate without actually cutting into it. And then finally, our own Srinivas Kishore, Dr. Srinivas Kishore from Hyderabad, who will explain the differences in different types of techniques and the nuances in different types of techniques, so that you can very well understand what technique will be suited in your hands in your patient. So let me have the opportunity to first invite Dr. Simab Sheikh to share his views and his presentation with you. Over to you, Simab.
Hi. Thank you, Vikas. Good morning, everybody from everywhere. Welcome to all the viewers, and a very, very big thank you to Mr. Sahai, Mr. Mahindra, and Sun Pharma for supporting us in this venture. And without getting into too much, because we're all colleagues and friends, I think I will start sharing my screen and get on with the show. So just please let me know once the screen is there and it's
Yes,
visible.
it is very well visible.
Okay, so I'm going to put it on presenter mode. Okay, so we are going to discuss today about the role of minimally invasive multi-level surgeries in OSA. And at the outset, although I use a lot of the RF coblation, etc., I have no vested interest in any of the companies that I would be making a mention of in the presentation. And this presentation is in complete accordance with the MCI guidelines laid down for speakers in collaboration with the pharma industry. So what exactly constitutes MIMLS? So minimally invasive multi-level surgery. What may be minimalistic for you may not be so for the patient or for another colleague, right? But that's a very different discussion in itself. So we won't even get into that. We have to understand just two concepts. There is MIS-MLS, that's minimally invasive single stage multi-level surgery, or there is the direct MIMLS. Both terms are almost the same as AHI, RDI, as we kind of interchange all of them. But for all practical purposes, start my video. Okay.
Yeah, Simab, you should keep your video on so that people can see you.
Yeah. So for all practical purposes, I will restrict this talk to the use of RF either by coblator or RF with the management of OSA surgeries for the palate as well as the tongue case. So just simple basics. RF is very simple energy. It creates ionic agitation, heats the tissue, thereby destroys the protein coagulation, causes the fibrosis, and then there's volumetric reduction. I don't really want to get into all of that too much. It's simple basic physics of RF, and it's much, much lesser heat energy than electrocautery. So the various machines that we used to use, I started off using Elman, then we used Ceylon. I've not had too much of Gyrus, but Sutter is what we tend to use. And what you need to understand is that the maximum diameter of the lesion that you get would be something in between the probes. So I will show you that probes, and then you'll have to understand this.
Right. So this is how we do it. This is the probe, and you'll be able to see the protein coagulation when we start. So the protein coagulation happens in between the two prongs, and it can go maximum to 0.3 mm around the two bipolar probes. So as you can see that happening, and there it is. That's the coagulated protein. Now this protein, actually when we pull it out, there is a resistance to pull when we're getting it out of the tissue. And that's how you know that the coagulation has completely happened.
That's how the RF actually works, and that's the probe, the palatal probe, which will have an insulated part which remains outside, and this is the part that gets into the palate. There's a good curvature for that, so that it helps you get angulated into the palate. So I'm going to show you a very amateur earlier video to be able to understand under GA when we used to do it. Note the pull of the tissue as you pull out the probe. So when you insert it into the palate, your angle has to be such that it should be somewhere middle in the mid part of the thickness of the palate. That's why the angulation is given, so that in the open mouth, you are able to then insert the probe, get the lesions done, and then create the lesions as needed. Now, having said that, you saw that the procedure becomes very simple to do, and it sometimes gives you a feeling that you need to do multiple insertions. And this is a little bit dangerous, because as if you have too many insertions and you know that the lesion is beyond that probe by about 3.3 millimeters, multiple lesions together side by side would land up in a huge palatal perforation. Now, fortunately for us, these perforations tend to heal well, because invariably, whatever you do, you are never going to be able to be in the middle of the thickness of the palate. So you have to understand that when you are inserting it in the palate, you don't have an exact idea whether you're going to be more posterior or anteriorly, and invariably prevent the posterior through and through insertion of the probe, you always land up tending to be a little bit more anterior. So you can have a lot of issues. That's the reason why you can also watch very little spaces and space them a little apart, medium, midline, paramedian, and apart, and you see the blanching. You know that the tissue has got ablated, and then you pull it out, and then you go ahead. Now, like I said, invariably, that was under GA. You can obviously do these very simply under local as you get the hang of it, and you need cooperative patients for that, because there's a lot of gag reflex, and then you have to pull down the tongue. You have to have them in a 30-degree up position. So it takes a little time. You need a little bit of a cooperation from the patient, where he will not gag so much. And invariably, that struggle of trying to insert the probe properly in the middle of the palate with a conscious patient is going to cause a lot of superficial ulcerations. Now, this is what happens many a time, and I can show you n number of cases where there's always going to be palatal ulcerations, mostly on the oral side, because we are trying to be very careful and not go posteriorly. So we will see most of it in the front on oral side. We have not yet been able to really find out what happens from the nasopharyngeal side of the lesions that are created. We hope to probably try and put in scopes and see that. So you'll see multiple cases, multiple places where the lesions will heal, but they will heal in time, in about 2 to 3 weeks, and then that creates a decent amount of fibrosis for us to use. So multiple cases like this, you will be able to do that very easily under GA or under local. So things to understand about these are that they are very simple procedures to do. They're very easily tolerated, and presently we're not even using too much of antibiotics. In fact, I don't use antibiotics post these procedures. Painkillers as needed. The patient will always suffer from a globus sensation, but that will last only a few days, and there's barely any chances of infection or bleeding. It's more theoretical. And obviously the significantly pain is way lesser than any of the other procedures that you get done. But you need to select the right palate. So if you have a very thin palate, it's not going to be a good candidate for RF, because you will land up with palatal perforations, or you may land up with different vectors pulling it laterally, and the contractions may not be as effective. In a very thick palate, so let's say you have a palate which is literally falling onto the posterior pharyngeal wall, with the thickness and a very thick uvula, then we know that these are the ones that are not going to be affected with the simple procedures like this. So you may need to actually do, when you have a really thick palate falling onto the posterior pharyngeal wall, zetaplasty would probably be required, because even the others may not really work that well. So you have to select your RF or the palette for which you're going to use the minimally invasive work very, very carefully. And that's where maybe to a certain extent a cephalometry would come into the picture, because you can possibly measure the thickness in some cases, or you can do scopies to see behind. Now, the procedure being simple, we had our very known people, the Riley Powell group with Galimanol. They have done and this was way back in 2000. So they've done an extended follow-up of these cases where the RF was done on the palate. And they initially found that the reduction initially was probably very good, but the reduction was in terms of snoring and EDS. But later on, again, the results went down and got down to only about 29 to 30%. But the better part of it is that even though they were a little low on the results initially, a lot of people were very satisfied with the simplicity of the procedure, and they were willing to repeat it again. And they had to repeat it in almost 33% of patients. So that gives you an idea of the simplicity of the procedure, the simplicity post-op, less complications, but at the same time, since it's less invasive, results aren't going to be all that great and miraculous. Now, if I have to talk about the RF of the tongue base, the probe is slightly different. So the probe is pretty much more angulated, more obtuse angle. It is more thicker because the tongue base needs much more thicker and much more pressure to insert that into the tongue base. And the rest of it remains the same. Machines depend on which one you want to use. The differences that I will want to point out, I didn't talk to you about consent of the palate, but that's almost pretty much remains the same. But in a tongue base, the potential complications and the airway concerns make it a little bit more important to have a much more detailed consent, because by and large, a tongue base is never done as a single stage or the only standalone procedure using RF. So it's generally always a part of a multi-level procedure in your entire bunch of surgeries that you have offered. But here the consent needs to be more important. You need to talk to them about the risk of post-procedure monitoring, and if possible, try to keep them overnight. Depending on the logistics of where you work and where the patient has come from and what kind of situations are, you can always do it as a OPD or as an IPD procedure. That's an individual decision that each surgeon has to take for themselves. So if you see the based on RF, it can be done, it has to be done, or rather can be done in the midline as well as side channelings. So channeling procedure in the midline does not really matter, even if you are in the anterior or a little in the posterior part of the tongue base, because it's very simple. You can see that the probe has just got to be inserted inside. And like I told you, it's never a standalone. So it's always with some other procedure of the palate that is combined. You see the probe being pushed in. Now this is a unipolar probe of the RF machine itself. We go down till the electrode is insulated, and then you can see the twitching on the tongue. And you can do this in 2-3 things right in the midline. We are way away from the neurovascular bundle, so that will really not create too much of a problem. The interesting part in tongue-based channeling is when you do it from the side. So if you see, your probe has to be directed more a little medially and a little towards the cranial side of the tongue, right? So you check that. And the important part, as you see here, is you've got to remain above the mucocutaneous junction of the tongue. So the minute you are in that plane above the mucocutaneous junction of the tongue, you are extremely safe from the neurovascular bundles, which are almost 2 centimeters deeper into the tongue tissue. So with this kind of a thing in mind, if you direct the probes medially and let's say caudally, cranially rather, then in that case you can have multiple side channelings that you can do. And as long as you are above the mucocutaneous junction, but yet in the deeper part of the tongue, in the muscular part of the tongue, then there is generally not a problem, and the ulcerations and even the neurovascular bundle issues really don't come too much into the picture there. And you can have at least about 4 channeling insertions done on the side also. Now there are 4 or 5 sites per sitting, each one about a centimeter apart. And although we say 750 joules per site per sitting, To tell you very honestly, I have really no idea how they calculate it, and I have really no idea how the machines deliver that specified here because they're all preset. So this is very theoretical point that I put up. But the fact of the matter is 4 or 5 sites channeling for about that 10 seconds. You see the muscle twitching, and that can really help. The important points in a tongue-based RF are the fact that you definitely cannot do without antibiotics. You have to use antibiotics. You have to make sure that the area is well cleaned and scrubbed, literally like a pre-operative site where you use chlorhexidine. You can even to a certain extent clean very, very roughly with a Savlon gauze if you need to. Bad taste, betadine here and there, yes, but still. And you ask the patients to do gargles at least pre-operatively and make sure that you are deep into the muscle of the tongue. But the antibiotics and the proper cleaning of the surface of the tongue becomes extremely important in this case. Now, there's a lot of fear that is involved with RF tongue base in terms of complication. And when it initially came in and started off, the tongue base abscess was the biggest thing that kept everybody away. If you see literature, you see, and even out of experience over so many years, what we talk about the tongue-based hematoma or the tongue-based abscess is very, very less. Yes, you will have altered tongue taste sensations, a bit of tongue numbness, but even if you look at it in the long term, the two major complications two most common complications that you get generally a little bit of pain and a little bit of edema, and these can very well be handled by simple painkillers, not even necessarily diclofenac, even to sometimes even by 650 milligrams of paracetamol and occasional use of glucocorticoids. So I think the complications for an RF tongue base have been a little overhyped, but having said that, of course, it can happen to anybody anywhere. And you can then assess the tongue-based RF results even post-operatively, objectively, by seeing the amount of airspace that can be increased. And that's what they've done. So the results for the tongue-based RF are checked with volumetric reduction assessed on MRIs. You can also see that the improvement is almost about 15% in the posterior airspace, and small things like speech and swallowing remain unaffected. And again, those results published way back again, that was 2000, 2001, same place, same timings almost. They were the same group, Riley Powell, were publishing the results in the American Academy meets at Denver, where they had a long-term follow-up of about 2 years, and the initial improvement again relapsed by about 50% over a period of time. So why this is important? So you have to now understand the importance between the RF tongue base and the excisional tongue base procedures. So if you look at it whichever way, the RF tongue base is definitely more easy to do. It's very easily repeatable, less complications, recovery time is much less. And the results on both of this as compared to excision would depend on when you position this treatment in your entire treatment plan, right? So obviously RF tongue base is much, much easier to do than the excision. But again, having said that, see the results. So if you were to compare results between an RF tongue base and an excisional procedure of the tongue base, hands down excision will give you better results any day. Now the reason I put up this slide is that I'm again trying to imply and tell you very, very categorically that yes, minimally invasive procedures will have minimally invasive or lesser results as compared to anything which is more invasive. So this very amply proves it, that yes, it is way easier to do. You can repeat it, you can do all that. But if you look at the comparison with excision at different stages, excision will still score over tongue base. And what I mentioned, that it is never a standalone procedure. It's always going to be in conjunction with some kind of a procedure, either on the palate or in the hyoid suspension. And enough position statements have come out in literature for you to be, very sure that the mild to severe OSA cases can be very successfully treated with the radiofrequency tongue-based ablations. So RF tongue base will eventually score above anything else only in those kind of patients where they have been operated, where other procedures may not be possible for that matter, or the patient may not really be willing for it. Now you have to now understand where to position these minimally invasive surgeries in your entire armamentarium. Like I said, make sure that you are in the muscular tongue, and you can definitely have repeated sittings. Now, to plan it in your entire management, you need to select the planning or select the kind of patients where MIMLS will be really helpful. So patients of simple snoring who are really not interested in any of the surgical options that you may offer, because we as surgeons obviously know that simple snoring is something that I would love to treat because it has no complexities of the apnea involved. And if I find a possible obstruction somewhere, I will straight away go ahead and want to remove that. But then if the patient is not willing, that's where the MIMLS comes into the picture. It will also be helpful in that protocols where you have a mild to moderate OSA who is refusing to do anything and is on CPAP but is also partially CPAP intolerant. So in those cases, let's say for example a hypertrophied nasal turbinate. So you use an RF on the nasal turbinates. You also try to use an RF on the palate to try to shrink it to whatever level you can so that his CPAP tolerance increases. Now, I didn't touch on RF turbinate because recently Jeevan has already spoken on nose, so I didn't want to get into the RF tongue turbinate part. Similarly, when you have a floppy uvula or a very soft palate in a mild to moderate OSA case, again, who is not willing for any kind of other procedure where you think, okay, I know I can do a fantastic barb, which like Philip is going to show, or I'm going to do some kind of expansion. I'm very confident that I can do that and the patient will get better results and I've assessed properly, but you may not be able to do it for whatever reasons of patient unwillingness or maybe not fit for surgery in that kind of way. So this is where the role of MIMLS will definitely come in. Again, it will come in patients who have already been operated for palates and have probably been not successful. And in your scopy, you're probably seeing other places. But this is what happens in a lot in practice when you see. So if you have an initial very, very extensive surgical procedure done, which has probably not given good result from the patient point of view. I'm not talking about the surgeon. We may have assessed, we see results, we are happy, but the patient may not be happy and he's undergone all that surgery and has gone through a bit of pain and everything for that 8-10 days. These are the kind of patients who, when they come to you, are not very accepting towards doing another invasive procedure. Now that's where again MIMLS will score. And this does happen a lot in practice, as you see on a day-to-day basis with a lot of patients. And you need to then post-procedurally assess the airway with CBCTs that are coming in now. MRIs have already shown you. So having given you this kind of an understanding, so why MIMLS? So like I said, it's very minimally invasive. And when you cannot do something very big or very good, exclusively excisable, then you might as well do smaller things in small, great ways. It was considered to be economical, but I keep that as debatable because a lot of us who are institutionalized now, any kind of procedure does come with a cost in an institution. Maybe in a separate individual private nursing home, this could be a debatable issue, but I think economy does not really matter into the picture when you're doing multiple sittings of the patient at that time for that one particular reason. And similarly, although that's why we do MIMLS, that's also one of the reasons not to consider MIMLS, because you cannot expect miraculous results from such simple, minimally invasive surgeries, which are positioned in different parts of the program of your treatment. And the size of lesion obviously will be small, and that's why you'll have to have multiple sittings or multiple insertions spread over a number of sites, but you will have limitations to the number of sites that you can give this insertion into. Now, this is a concept that I would like to leave everybody behind with, those who are thinking towards MIMLS. This is something that we are broadly propagating even at the association levels, and hopefully once our association is out with the guidelines for surgical management, this would be part of that protocol. So we're talking about 2 minors and 1 major is what should be your surgical armamentarium at one time if you really want to do in terms of safety. So all channeling procedures are so-called classified under minor, and all the excisional or relocation work is then classified under major. So 2 minors. So let's say you're doing a tongue-based surgery, you can always club that with a radiofrequency turbinate and a radiofrequency palate. That should not be an issue. Let's say you're doing a hyoid suspension, you can always club that with a radiofrequency tongue base and a radiofrequency palate, and to a certain extent maybe in a radiofrequency turbinate. So the fact of the matter, or let's say you're excising the palate, you're doing some kind of a excisional work, you can always add on a tongue-based RF to that, or maybe a tongue-based radio frequency turbine. So two minors and one major is a very sensible way of placing MI-MLS in the surgical armamentarium that we have. And there's ample evidence-based results out there. You can always look into it, and you will see that the minimal invasive surgeries for patients with OSA definitely improves lots of things on the parameters that we have. And a proper counseling and a proper understanding will give them even better results as what the patient expects. So any amount of literature you go out and see, you will realize that what MI-MLS actually does is here. So the two major things that really improve with MI-MLS is the snoring severity and the daytime somnolence after these single stage or multi-level minimally invasive work. And this has been amply proven. So is there evidence-based data is out there to support MI-MLS in that fashion, provided you kind of position them well in your treatment protocol. Now, if you realize the patient's choice, and this is a statement that I'd like to make, it's my own statement. So complete transparency in explanations of procedure, its expected outcomes, and the alternatives available. Once you explain this to the patient, a lot of us would be surprised as to how many patients today would choose MI-MLS over other options available. And as you get into practice, as you do a lot of this with a complete transparency in explanation to them, you will realize a lot of patients today are choosing and opting for slow, steady treatment. Of course, this does not bring into the picture the medical tourisms and the ones that come from outside your city to you and things like that. But believe me, as you practice, you will see this change in mindset of the patients. So I'd like to leave you with a few parting thoughts that although as surgeons for us, success in medicine would be, evidence-based medicine, because that's what we need to prove, and it's all a bunch of numbers and figures. But in practice, your patient satisfaction rate and what he actually feels out of the whole thing is what is going to really be important also as you start treating the patient. So thank you very much for this listening, and I will now hand it over back to Vikas and sit by the side till we finish our session.
Thanks, Imab. It was a really very nice talk. Though we'll take major questions at the end, but there's a very important question which has come from Dr. Jagan Mohan Reddy. RF may be useful, especially in the COVID era, as its temperature is high, even the virus will be burnt. So what do you suggest?
So COVID era, everything and whatever we are doing is all guesswork. Yes, logically what you say is absolutely true, but it all, again, like we said, now we are so evidence-based that we will have to wait for time. Right now, I don't even have a single case in the COVID era for me to have done an RF, so I really don't even know what is going to happen with COVID patients in RF.
Correct. And the answer to that also is that viruses are present in the secretions, oral cavity secretions. It's not in the tissues that when you go inside the tissue and burn that, the virus will get burned. Another question is from Mexico, Dr. Perla. How would you manage an hematoma if present after RF BOT, base of tongue?
So it's going to be a difficult one. Obviously, we're going to have to intubate the patient, keep it intubated. If there is hematoma, this is purely theoretical because I have not really handled anyone as yet. But we will have to probably drain it, keep the wound open, and then keep on the antibiotics and wait for the wound to heal. And keep it, try and keep the area as open so that any further collection can drain out. If there's an active bleeding, then we'll have to probably go in with a coablator wand or something, locate the bleeding and try to stop the bleeding.
Very nice, Sima. So thank you, Sima, for the very nice lecture. And I now invite Dr. Filippo Montevecchi from Forlì, Italy, to make his presentation on the barbed pharyngoplasty, how to master the technique. Dr. Filippo.
Good morning. Thank you for the invitation. Can you hear me?
Yes, very well,
Okay,
Filippo.
perfect. I'm sharing my screen.
Yeah.
Let me know if you see my presentation.
Yes. Now, yes, you can put it full screen. Yes.
Okay. Is it
perfect?
Is
Absolutely all right.
Perfect.
Go ahead.
Okay. So I'm going to talk about barbed pharyngoplasty. I have worked for 15 years in this hospital, Morgagni Pier Antonio Hospital, with Professor Claudio Vicini, and we have developed the program in sleep apnea surgery. Last year I moved, always in Forlì, in this hospital, Ospedali Privati Forlì, and I'm still going ahead on my sleep apnea program. So my city, Forlì, is in the northeast of Italy, in a beautiful Italian countryside. This is the square of the city. Talking about palate surgery, this is our series till 2013. We started by performing LAOP, laser-assisted uvuloparyngoplasty, but we stopped to do it because of the unpredictable scar after laser. Then we use UPP. UPP was a good procedure, but there were two main problems. The patient could feel the scar in the free edge of the soft palate, and we couldn't address lateral walls. We have used UPF, uvulopalatal flap, but in a few patients, mainly for snoring. And then we have used expansion sphincter pharyngoplasty. Expansion sphincter pharyngoplasty is really a good procedure. You can address the lateral walls. But in 2013, an Italian doctor, Professor Mario Mantovani from Milan, published this paper, Barbed Roman Blinds Technique, by using bidirectional barbed suture. We read this paper. It was really interesting, this paper, with by using this new device. You can see the suture with some barbs everywhere along the suture. And the suture is a long suture, bidirectional, with two needles. We start to perform barbed pharyngoplasty. Along the years, there have been developed many kind of sutures. We started with this kind of suture, and then we move to this one, and I explain why. Have a look at this suture, Stratafix. It's a good suture, but in this case, you see the size of the needle is 36 millimeters. Now we use this suture, 26 millimeters, the needle. It's important to understand why. If you have a big needle, the steps in the soft palate are easier. But the problem is when you enter in the tonsil fossa, perform the steps in the tonsil fossa is more difficult if you have a big needle. Instead, if you have a small needle, is more simple to perform the maneuvers. Furthermore, V-lock has different barb, and we can use a smaller suture. We use a 3/0 or a 2/0. Instead, by using this kind of suture, we have to use a 0. So this suture is more flexible. It's important when you perform this procedure to use a very strong needle driver. We use this needle driver, it's a maxillofacial instrument, because the grip for the needle is very strong. Otherwise, inside the needle driver, the needle will twist. So nowadays, in my opinion, this is the best suture. V-lock, it's an absorbable suture. It absorbs in 180 days, 6 months. I prefer to use not 36 millimeters needle, not 26, but 30 millimeter. 30 millimeter, in my opinion, is the right compromise, and I prefer to use a 2.0 because in this suture, barbs are the more effective. This is just my opinion. I don't have a paper to show you. I don't have scientific data. If Stratafix is a bidirectional suture with two needles, V-lock is this: one needle, the suture, and one loop. So to have a double needle, you have to link to suture with a knot. It's easy. You insert the needle in this loop and you close the knot, and after that you will have a double suture with double knot. When we perform lateral pharyngoplasty or expansion pharyngoplasty, we have to develop a flap. It's not necessary in bad pharyngoplasty. Performing the flap is not difficult, but it's not easy. Probably it's better if we use a magnification device to understand where are the fibers of the palatopharyngeal muscle. The fibers run vertically. Instead, in the superior constrictor muscle, the fiber run horizontally. So if we use a magnification, a loop or a microscope, we can see very well this kind of fibers. But if we touch the superior constrictor muscle during the dissection of this flap, we can enter in the parapharyngeal space, and it could be a problem. Inside the parapharyngeal space, we have a very large number of structures, jugular vein, branches of external carotid artery, other veins, so could be dangerous. So it's especially in if you have a very low volume of cases, could be tricky to perform this kind of procedure. And probably by using barbed pharyngoplasty, the procedure will be easier for surgeons. At the beginning, by using lateral pharyngoplasty or expansion pharyngoplasty, we attached the flap to the pterygoid annulus. In some cases, in some patients, it's not easy to locate the pterygoid annulus. The pterygoid annulus is the tip of the medial pterygoid plate of the sphenoid bone. So it's not always easy to locate the pterygoid annulus, but it's always difficult to turn around this annulus a suture. For that reason, we started to use the pterygomandibular raphe. This is the pterygomandibular raphe. I show you in a better way. So in this picture, you can see the soft palate, and this is the pterygomandibular raphe. Pterygomandibular raphe is a tendons. The tendons, the pterygomandibular raphe start from the annular process here, covered by mucosa, and gets attached to the mylohyoid ridge. In this picture, you can see better the anatomy. So the raphe, the annulus, the annulus, and then laterally you have the buccinator muscle, and medially you have the superior constrictor muscle. This is the anterior pillar, and this is the posterior pillar. The posterior pillar is the palatopharyngeal muscle. So by performing the new pharyngoplasties, you move the palatopharyngeal muscle anteriorly and laterally to the raphe, and you, by performing loops by your sutures, you can attach or you can get closer to the palatopharyngeal muscle to the raphe. Let's see the vectorial analysis. So we start by our suture from the midline of the soft palate. By a needle, we go right, and the other needle go left. So we have to start some millimeters close to the hard palate, in the soft palate, but not too far from the hard palate. Why? Because if we read this paper, very interesting paper, we can see the anatomy of the soft palate, the uvular muscle, and there are two other muscles, the levator veli, this one, and the tensor veli. The tensor veli in the midline has another aponeurosis. So we have to attach our suture at the beginning in this aponeurosis. It's really important. So we start from the midline and we go right, we exit here, then we enter in the same point and we exit laterally to the raphe. This is the raphe. We have to exit laterally to the raphe. Why we perform this V-shaped line? Because if we perform a straight line, we don't have a posterior superior vector, this one. Instead, if we perform a V-shaped line, pulling up this suture, we can move the palate in this way. So this is the first movement of the soft palate during this procedure. So by using this procedure, we can manage even the central aspect of the soft palate. From this area, then we insert the needle in a tunnel and we enter in the tonsil fossa. Inside the tonsil fossa, we grasp the palatopharyngeal muscle and then we come back laterally to the raphe, moving this pillar laterally and superiorly. Then, according to the anatomy of the patient, we can enter other times in the tonsil fossa and we can do the same. We grasp the muscle, the palatopharyngeal muscle, and we come back to the raphe in different area of the palate. At the end, we come back medially and we cut the suture at this point. This is the final view. And usually after the surgery, the orange area is the old space. After the surgery, we have a new green area enlarged compared to the beginning. Let's see the video. So we are in the soft palate, tongue base, sorry, the tongue. So we mark the point between the hard palate and the soft palate. Then we have to locate the raphe. It's quite easy. If we touch this area, we can feel the raphe. We are drawing the line of the suture, and you see now before using the suture, we release a little bit the palatopharyngeal muscle. It is not necessary to develop a muscular flap, but just to release to avoid too much tension at the end of the procedure. We have to release the palatopharyngeal muscle. Then we start by using the suture. So during this procedure, we used the Stratafix, the old one suture that is more rigid and has less barb. As you can see, the needle is big. If you have a big needle, it's easy to perform the first steps. So this one, and enter in the tonsil fossa. But even if you use a smaller needle, you can exit maybe one time more in the soft palate. It's not a problem. You have to enter always in the same point where you are exit in order to cover completely the suture. So we go ahead. We did the first step. We enter in the same point, and we have to exit lateral to the raphe. Okay, you see, this is the needle. We exit lateral, but not too lateral, because 1.5 centimeters from the raphe, there is the duct of the stenone duct. So we have not to damage this important structure. So we go laterally to the raphe, we pull up, and then at the same point we enter, we make a tunnel, and we exit in the tonsil fossa. By using a 36 millimeter needle, this maneuver is very easy. By using 26 millimeter needle is more difficult, but it's possible. We grasp the needle inside the tonsil fossa, we pull up every time, and you see no suture outside the mucosa. It's always inside the muscle. It's important because if you stay just below the mucosa, the suture doesn't work because it cannot grasp the muscle. You have to stay inside the muscle to grasp the tissue, the muscle tissue, and to avoid the feeling of the suture to the patient. If you are too superficial, the patient can feel the suture and you can have extrusion of the suture. So when you are inside the tonsil fossa, you have to create a loop around the palatopharyngeal muscle. Usually, I suggest you to do this, to perform this step by using the needle from lateral to medial, because you can have a more effective step, and you can move more lateral this muscle towards the raphe. So it's important, if possible, to stay always inside the mucosa, inside the muscle. Don't go out the mucosa. The first loop was created. Then, to be sure, we create another loop, so another step in the palatopharyngeal muscle. After these two loops, we come back to the raphe. The needle. We grasp the muscle in this place, but it's not important to grasp when we come back. It's important, in this case, the first bite, the first step, it's important to exit as much high as possible in order to move laterally and superiorly the pillar. We pull up and we move without knots the posterior pillar towards the raphe in this way. Then we start with the right side. It's the same suture with two needles, but I stop just a moment at the video. Before completing the left side, I suggest you to start the right side because it's a symmetrical procedure. It's a mistake to finish all the steps in a side and don't start in the other side. We have to go step by step in the left and in the right side. We start the right, the V shape. When we pull up the suture, you see there is a movement up. We move up the soft palate. Then we enter at the same point. We enter in the tonsil fossa by using 36 millimeters, again, by using 36 millimeters needle. This step is very easy. But when we are in the tonsil fossa, it's more difficult by using 36 millimeters needle to perform this step, especially in patients with a small mouth, a small pharynx. Is difficult to perform this step with this size of needle. I prefer to use a 26 or a 30 millimeter needle. We have to grasp as much tissues as possible, always inside the muscle, not outside the mucosa. 2 loops, and then we come back laterally to the raphe. You see, we exit, I show you, we exit here. We don't exit here at the first step, because if you exit here, you have just an horizontal vector. If you exit here, you have a lateral and vertical vector. It's much better for the palate. We grasp the needle, we pull up, and you see the movement of the posterior pillar without knot. Then we come back to the left side. We perform, according to the anatomy of the soft palate, another step. So in this case, we have to move this aspect of the soft palate. We come back and we pull up. Pulling up the suture, you move the posterior pillar. In the right side, in this patient, we have performed three passages every side. I go ahead. At the end of the procedure, we go medially again to finish our procedure, and we cut the suture close to the mucosa. So you see at the end of the procedure, no suture. It's important to stay always below the mucosa, inside the muscle. And this is the finish, the end of the procedure. So 1 month after the procedure, this is the result. You can see a scar just in the upper pole of the tonsil fossa, and usually there is an edema of the mucosa for some months. Sometimes you have an extrusion of 1 centimeter of suture is not a problem. You have just to cut the suture close to the mucosa. The other part of the suture will work, we still work. This is the pre-op view, and this is the post-op view, the soft palate and the posterior wall. Of course, we would like to see this result in all our patients. About the time of the procedure, within 10 or 15 cases, the time is less than 20 minutes. It's really a very fast procedure. It's not difficult. You have to understand some steps, but it's a easy and fast procedure. So we have tried to give you a evidence-based medicine. This is our first paper about the first cases about the reposition pharyngoplasty, published in 2015. Then we publish a multicentric study. It's important because sometimes you have a very nice technique, but only in one center. If you cannot reproduce your technique, is not so effective, the technique, if only one can use the technique. Instead, we could demonstrate that it was possible to perform this suture in many centers, both in centers with a high volume of patients, but even in center with a high volume of patients, 2-3 cases every year. You can perform this kind of technique because it's not so difficult. And in 2019, we published this prospective randomized trial. We close the story, publishing this paper, and it was really a satisfaction. So summarizing my last slide, this technique is easy to learn, easy to perform, quick, safe, cheap. Cheap because one suture costs about $30 and you need one suture. Effective, minimal side effect, and high patient compliance. Thank you for your attention.
Yeah, thanks a lot, Filippo. There are a lot of questions for you, and your talk was really wonderful, and it has evoked a lot of questions. Let me ask you some relevant questions at this point of time. That you said that you use one suture, Stratafix, which is bidirectional.
Yes.
So when you use the Covidian suture that you showed,
Two.
then you have to use two sutures.
Two
That was one.
Yes.
Dr. Deepa from Bangalore has asked, how deep is the bite? So I believe the answer is muscle deep. It should not be mucosa deep, and it should not go into the other side. Is that correct?
More than correct, yes.
Okay. The third thing is that uh, if it is an absorbable suture, as you said, it will absorb in 180 days. Then what will happen after 180 days when the suture is absorbed?
What happens when you perform a reconstructive laryngectomy? Do you use absorbable suture as well? And after 180 days, the larynx doesn't open. Why? Because there is a scar. The same in the soft palate. If you have a suture for 180 days, there will be a scar. And I can tell you the same for the expansion pharyngoplasty. What happened after 180 days when the suture, why the flap of expansion pharyngoplasty stay inside the muscle? Because there is a scar. The scar will work for us. There is a fibrosis along the time that stiffen and block the palate in the new position.
Okay. The next question is that what happens to snoring? I understand you have a very good study on the efficacy of this procedure for sleep apnea, reduction of AHI. But since the uvula is in place, the base of the uvula is still fluttering. So what happens to, does the snoring actually go away?
Yes. It's not mandatory to leave completely the uvula. Some surgeons prefer don't touch at all the uvula. If I have a big uvula, I reduce the uvula always. I don't cut completely the uvula, but I reduce the uvula. Is it true? It's true that after BARD, there is an edema on the free edge of the soft palate and in the uvula. This edema lasts sometimes more than 6 months. And if you have edema, there is more snoring. Okay. I don't know. Probably inserting all this suture in the soft palate, there is a problem in the lymphatic drainage. Probably. I don't know exactly the mechanism, but probably it's for that reason. Anyway, if you see, and I didn't show you the new step of the BARD suture. At the end of the procedure, you can create like a net in the soft palate, moving the needle from the right side to the left side in the soft palate, and from the left side to the right side. So you, according to the anatomy of the patient, you can use this suture as you want. If you create like a net in the soft palate, you stiffen the soft palate because you are right. After BARD, maybe you can manage sleep apnea, but sometimes you have to manage even snoring.
Correct.
And for managing snoring, you have to stiffen the soft palate. So you can create a net by using the
Yes.
suture.
Correct. This question from Dr. Munka from Bokaro. Do you pull the thread at each step or you pull it after doing the whole thing? So I think you have already explained
No,
that after each step.
yes, you have to pull every time you exit. It's better to pull. In this way, the bulbs will grasp the tissue. So it's important. It's mandatory to pull up every time the
Correct.
suture.
There's a question from our dear friend Rodolfo Lugo from
Oh,
Mexico.
hi, Rodolfo.
Yeah, Rodolfo. Dear Vikas, nice webinar. You can ask Filippo. In BRP, our feeling is better the dissection of the palatopharyngeus muscle, like Kahali does, but without the myotomy for more easier mobilization. And in his video, we are only seeing muscle pull. So how can you explain on that?
Can you
I'll
repeat the
repeat the question.
question?
So
Yeah,
he's saying in BRP, the better the dissection of the palatopharyngeus muscle, like Kahali does,
yeah,
but without the myotomy
yeah.
for easier mobilization. And in your video, he has only seen the muscle being pulled. So why do not you take, complete cut in the palatopharyngeus as Kahali does? That's what he is asking.
So, according to the anatomy of the patient, you can dissect more or less the palatopharyngeal muscle. Why not? So it's an idea. Why not use Bard in the Kali, in the Michel Kali technique?
Right.
It's Bard is just is not a technique. It's a suture. You can
Right.
use this suture for any kind of surgery. Anyway, if you have, for example, big palatopharyngeal muscle, you can dissect a little bit more. It's not a problem. You can mobilize a little bit more the muscle. It's correct.
So there are many questions for you. I think I'll take them at the end because Srinivas also has to present, and let him first talk on the nuances of palatal surgery. So I'll put you on mute, Filippo, for some time till Srinivas finishes his talk, and then we'll come back to you because there are a lot of questions from Mexico, from Poland.
Okay.
All our friends are asking questions. I'll come back to you.
Okay.
So thanks, Filippo. And now it's time for our dear friend Srinivas Kishore from Hyderabad to talk on nuances of palatal surgery. So Srinivas Kishore, as you all know, has been giving very nice talks in all our conferences about different types of palatal surgery. So I would expect Srinivas to explain which palatal surgery he will like to do in which case and how does he take a decision, because there are a lot of questions on that, what kind of palatal surgery to do in which case. So over to you, Srinivas, on your talk on nuances in palatal surgery.
Can you hear me, Vikas?
Yes, and I can see your screen also.
Screen also? Okay,
yes.
1 second. Okay.
There's
all right.
sound in your background?
No, not my background. My background, I think it's clear.
Okay, fine.
So,
go ahead.
Good morning, everybody. I'm Srinivas Kishore from Hyderabad, and thank you very much, Seema, and thank you very much, Filippo, for setting the stage for my talk, that is nuances in palatal surgery. Always learn something from your talks, Seema and Filippo. Thank you very much. So, we all know that obstructive sleep apnea is a condition caused by obstruction at multiple levels. Even though when we say it is at multiple levels, there is a lot of data out there that tells us that the soft palate is the commonest site of obstruction, and we do see it at almost about 85% of our patients. Hence, palate needs to be taken care of and needs to be addressed to. Now, what is causing palatal obstruction? there is a decrease in the retropalatal area and in the oropharyngeal cross-section area. That's what it means when you say there is a palatal obstruction. Now, what are you supposed to do? All you're supposed to do is to do a procedure on the palate to open it and stabilize it. But unfortunately, this is what we did earlier, because what was happening was our techniques were not good, our understandings were not good. And you saw how beautifully Filippo sort of, explained everything because of understanding of the anatomy, understanding of the pathophysiology of the disease. So what we used to do before in the form of UPPP has completely changed. Now, why? Even though if you look at, this is my own surgical picture, and the patient actually said, sir, I'm fine. I don't have any snoring. But if you do his polysomnography, and this is 5 years post his surgery, he had bad AHI, and I did a DICE, and what was looking in front like this was the moment he was snoring and he was sleeping was like this. So UPPP, LAUP was non-selective surgeries because we were not selecting our cases. We were thinking that we were eliminating the cause of obstruction, but we were not. But if you really look at all the data out there, and if you really see UPPP is one surgery in the surgical management of obstructive sleep apnea that has been thoroughly studied. And the success range was ranging from 80% to 20%. How is that possible that one procedure is having such a varied success rate from 80 to 20%? However, there is a very nice paper, and this is published in Laryngoscope as the best practice. And very clearly it is shown that there is level 1 evidence out there that if you select your patients properly, UPPP can have a success rate of about 80%. So this is not a surgery that you have to just fold it and throw it out of the window. It does still have some kind of role, but if you select your patients properly and not based on disease severity, but you have to select the patients based on anatomical staging, then you will have an 80% success rate. And this has been published as early as 2017. Now, in the past 10 years, there are lots of changes that have basically happened in surgical management of OSA. And we, as sleep apnea surgeons, have clearly moved on. We've become more innovative. We've become more precise and more customized. And as you saw in the BRP earlier, you saw in radio frequency application earlier, that we are able to systematically target the procedures instead of just taking a hammer and hitting every nail. Now, how have we evolved? From the 60s to where we are today, we are able to perform these newer reconstructive procedures that we call nowadays based on 3 principles. 1, we are able to address the exact anatomical site. We are preserving the mucosa and soft tissue while respecting the muscle and anatomical function of each of these structures. These basic principle paradigm shifts in our thought process have culminated in what we now call as reconstruction palatoplasties. So if you take a look at this picture, so there are 4 points here. 1, you preserve the mucosa. 2, you ablate the adipose tissue as much as possible. You preserve and suspend the muscle. And if you have lymphoid tissue, you excise it. These are, again, the basic 4 principles of any kind of a newer palatal procedure. Even in the newer barb procedures that are being done. The lymphoid tissue is excised, the muscle is suspended, the adipose tissue, if it is there, is excised, and the mucosa is preserved, as it is in any surgery in ENT. Now, the advent of dyes has basically changed the way we look at things. And if we are talking today about reconstructive palatoplasties and precise customization, it is dyes which has basically changed and brought about this thought process in our people. Now, the newer concepts of palatal surgery is structure, pattern, and severity based on dyes. Office-based procedures has been beautifully dealt with, Seema. What I'm going to talk to you about is reconstructive palatoplasties, excluding the barbs which have been beautifully spoken. Now, when you bring about a list of reconstructive palatoplasties, there are an array of them. There is anterior palatoplasties and the barbed versions of the anterior palatoplasty, the Michel Kahali versions of the lateral pharyngoplasty from 1 to 6, the expansion sphincter pharyngoplasty, based on which a lot of modifications have come up, the BRPs, a lot of techniques have been based on this procedure that has been brought about by Tucker Woodson and Kenny Pang. The functional expansion, the relocation pharyngoplasty, which is more popular in Asia, in Eastern Asia, and the famous BRP. So even in barb pharyngoplasties, even though BRP is the most famous one, there are barbed lateral pharyngoplasty, there is barbed anterior pharyngoplasty, and the original Alianza technique by Mantovani. I will not talk about the barbed pharyngoplasties because I think Filippo is beautifully done with, and I think he set the bar so high. What I will talk to you about is the finding on dyes and the kind of procedure that one would do. So, like I said, if you have an anterior obstruction, anterior posterior, which is one of the commonest kind of obstruction on drug-induced sleep endoscopy, this is a very simple procedure. And even though it looks very simple on the picture, and you yourself would know that it's a simple procedure, simple procedure necessarily doesn't mean bad results. In this very fantastic paper published by Kenny Pang, Brian Rottenberg, and Peter Baptista, they have done a 17-year meta-analysis, and they came out and said that this is one surgical procedure that achieved the best AHI reduction with a mean reduction of 24.7. So just because it is simple doesn't mean it doesn't give you results. So just quickly going to show you an anterior palatoplasty. So this is the palatal dimple. And as we spoke about in the principles of palatal surgery, we did speak about clearing of the lymphoid tissue. So this is the dimple. I'm using radio frequency. This is the Sutter radio frequency. You can use monopolar. The idea is to create a box of about 1.5 into 2 centimeter box. And then you basically clear off the mucosa there. And once you clear off the mucosa, you're going to expose the submucosal tissue. Now, it is very important that in addition to the mucosa, you remove a little bit of the minor salivary glands there also. Now, once you have this kind of a raw area, it's very easy. You can go ahead and do, so here I'm trimming the uvula because I feel it's a little long. So leave a little mucosa on the ventral aspect so that you can fold it. There are, again, it's not about the tool. It's again very important that you make these para-uvular cuts. Now, the reason why you need to do these para-uvular cuts is that you will get a nice box. Please remember, this is a procedure that is done for the management of anterior posterior collapse. Now I'm using regular 320 Vicryl, which is closed in the form of layers, 2 layers to be very precise. Now this procedure can be done with barb. There are lots of papers out there. I think, as Filippo clearly said, it's not about the, barb is just another suture. It's again about the technique and what you want to achieve at the end of the procedure. Now, another procedure that you can do for anterior posterior collapse is uvular palatal flap. This is a procedure that is very famous in Stanford, and a lot of us actually do it. Instead of the radio frequency, I'm using the Kublator SP wand. Again, remember, this is a procedure for anterior posterior collapse. So basically, you're cutting the medially arching fibers of the palatoglossus, palatopharyngeus muscle. The palatoglossus has been already cut. And once this is done, as you can see, there is no infiltration and you don't see any kind of charring. So you can put in 1 or 2 channels in there to sort of make this a little taut, because it's all about fibrosis and vector formation. And once that is being done, all you have to do is fold this procedure, fold the soft palate onto itself, and then you suture this in layers. And at the end of the procedure, you would get a palate which would look like this. And again, beautifully, you will get this anteroposterior expansion of your palate. Now, again, anterior palatoplasty, uvular palatoflap is for anterior posterior collapse. Now, there are many versions of lateral pharyngoplasty. I, for one, have not had any experience in this, but there is a lot of data out there, and I think we have to give it to the data. It's got fantastic results. It's not only in Kahali's hands, it's also in among other authors' hands that you get a pretty decent success rate. It's Professor Kim from Korea, who's got 78% success rate with this when we combined uvular palatal flap, which I just showed you now, and lateral pharyngoplasty. Dear friend Maria Carrasco from Spain, who's also got 70% success rate. There is a 100% success rate with Disdar et al. Of 20-month follow-up. So lateral pharyngoplasty, I think, is a fantastic procedure. From anterior posterior collapse, we have to talk about lateral collapse, because this is the second most common cause of obstruction at the level of the velum. This is a vibration, and DICE beautifully helps you to differentiate an obstruction from a vibration to a collapse. So now what was a vibration earlier now is slowly changing into obstruction. So what do you do for these kind of obstructions? The original version of expansion sphincter pharyngoplasty has been modified by a dear friend, Ottavio Piccin from Bologna in Italy. A lot of fantastic work has been done in Italy. Hats off to them. What they've done is, instead of basically routing through this, making a submucosal tunnel coming from the superior part of the tonsil to the pterygomandibular raphe, they just take a suture and fix it. It cuts off the surgical time much less. What I do is a combination of both the techniques, the classical expansion and the functional expansion. As Filippo beautifully told us, the difference between and how you should be able to differentiate between the vertically running fibers of the palatopharyngeus muscle and the muscles on the base, the other muscle in the base of the tonsil, which is the superior constrictor muscle. So when you talk about expansion sphincter pharyngoplasty, you have to make 2 vertical incisions in the base of the tonsil, a vertically running incision which is longer, and another incision parallel, so that you can cut this, as Rodolfo was asking whether why not cut this. Well, you can cut it, you may not cut it, you will have to customize it to the patient's needs, but it's very important that you not through and through cut this muscle in and button out into the mucosa of the oropharynx. As you can see, you've got a nice bunch of muscle fibers here. So where you want to cut this basically depends on the distance that this muscle has to travel from the upper pole of the tonsil to the pterygoid hamillus or the pterygomandibular raphe. Again, please remember that this muscle should still be tethered to its attachment below, because you are basically trying to relocate this from the bed of the tonsil into this area. Now, once you do that, you have to bunch all the fibers because you want them to stay, you don't want them to get ripped apart. So you suture, stabilize it. You use a same 3-0 vicryl or a 2-0 vicryl, and your colleague, your surgical colleague, will help you to keep a traction of it. Once this is done, an incision is made at the pterygoid hamillus and put in a curved hemostat and pull it. And then what I do, very similar to an expansion, is I put in suture. So what my technique is a combination of the classical expansion and the functional expansion, so that at the end of the procedure, you get a beautiful box at the end. And I would prefer a 2-0 so that you can actually take it from the upper part of the tonsil and to the pterygoid hamillus or to the upper part of the pterygomandibular raphe. And this is how it's closed. Now, if you look at it, 6 months, this is the FLP 6 months, you get a beautiful box. Look at this box. So the entire lateral wall looks exactly like this, and the patients are pretty happy. So if you look at the success rates, it's about pretty high at about 82%. And this is not my success rate. This is Kenny Pang's success rate. But I would definitely second this success rate. It has been pretty good in our hands too. Now, the other procedure that I would like to talk to you about is the modified Sam Robinson's. This is a slightly more aggressive procedure. So you make a triangular flap based on the pterygomandibular raphe. As you can see, this pterygomandibular raphe that is there beautifully. So you can use monopolar, you can use any of the cutting tools, it doesn't matter. It's not about the tool, it is about the fool behind the tool, as I always say. So it always has to be symmetrical. So your incisions, you better plan it even before, so that you don't want asymmetry in while making your palate. So the whole idea is to basically elevate a triangular flap. Once you elevate the triangular flap, which has been based on the pterygomandibular raphe, um, you would actually expose the supratonsillar fat pad. And I think this is this bunch of fat pad, it is very important that you cut this and excise this, the supratonsillar fat pad and expose this part of the superior constrictor muscle. So once you do that, you get a very good traction point to relocate your muscle from the bed of the tonsil. So the superior constrictor, the palatopharyngeus muscle, which is on the bed of the tonsil, you relocate it from there and you bring it. But what is most important is that you need to clear off this fat here and expose this entire area. Once that is done, the rest is to cut this part. Till here, it's very similar to the expansion. So once you do that, you cut this muscle, try to relocate it, cut this part of the medially arching fibers of the palatoglossus, and then hinge it. Once you hitch this onto this, you get a very nice anterolateral scar vector, which will open up your palate both anterolaterally, so that as the scar becomes more and more mature, your scar vector becomes hardened and this is also a uvula, sort of a uvula sparing procedure. But if the uvula is very long, you can also cut it to customize to the needs of the person. So at the end of the procedure, it looks like this. You can also give release in mucosal release incisions if the mucosa is very taut, because if you have mucosal tension, obviously you will have a failure of the procedure because there will be dehiscence. Now this is how it looks in the first, and here is a multi-level surgery wherein we did tongue base also with a modified Sam Robinson's technique. This is post-op day 5. As you can see, a huge improvement in the velopharyngeal area. So results are about 85 patients, 6 months follow-up, about 90% success rate. This is relocation pharyngoplasty. I will not go through the entire thing because basically, ultimately, it's the same thing. You have to remove the supratonsillar fat pad. The only difference here, and very similar to the Kahali technique, is that you take the supratonsillar, the superior constrictor muscle and suture it to the anterior pillar and don't cut the parallelly running palatopharyngeus muscle. Now, pretty success, the success rates are also quite good. There is no change in voice, none of these, and decent success rates. Now comes the biggest question. How do you decide what procedure to perform in your patient? So, to me, if there is an anterior-posterior collapse, you do an anterior palatoplasty and a uvulopalatal flap. If you have a lateral collapse like this, for me, it makes sense to do an ESP or a relocation pharyngoplasty, or in very thick palates, zeta palatoplasty. And if there is a circumferential collapse, you have to do combinations of procedures. Now, there is a lot of data out there that actually says that sometimes with the advent of the bar procedures, you can do a single bar procedure instead of combination of these procedures. And to me, if they are very thin, pliable pillars like this, you would either select any of the bar procedures or a relocation pharyngoplasty, because these procedures are minimally invasive. Now, barbs, of course, have been spoken in detail, so I will not go into that. But I would basically bring about this basic paper that I spoke to you about the combination of anterior palatoplasty and expansor sphincter pharyngoplasty and BAP. So again, this paper says that, BAP pharyngoplasty, BAP palatoplasty is equal to or superior to expansion sphincter pharyngoplasty. So, dear colleagues, at this must come to an end of it, but I would like to give one small slide here. Now, what are the anatomical factors that may contribute to a good surgical outcome? If you have large tonsils, you have a winner. You have an elongated uvula, you have a winner. You have webbing, the pliable posterior pillars, you have a good case. So low Friedman tonsil state, tongue position, you have a good case. Non-concentric collapse at the velar pharynx, you have a good case. Absence of tongue and epiglottic collapse on dice is a good prognostic factor for palatal surgery. Thin, long, soft palate without craniofacial anomalies in a lateral cephalometry is a good case for palatal surgery. And obviously, you have morbid obesity. You shouldn't you have morbid obesity. You shouldn't be doing any kind of palatal surgery. With this the little bit of understanding, I would like to end my presentation. Thank you very much.
So thanks a lot, Kishore. My voice is being heard?
Yes.
Okay.
Yeah.
So I think it's 11:30 and we have half an hour and we can extend to another 10-15 minutes more.
Sure.
There are a huge number of questions. So without any waste further time, I'd start, shooting questions one by one.
Yes.
Dr. Deepika from India has asked, can barbed suture be done in previous tonsillectomy patient? So Filippo, your take.
Yeah, absolutely yes. For sure, you have to remove the mucosa of the new pillar, because when you perform tonsillectomy after some time, you have a unique pillar in the oropharynx. You don't have anymore an anterior and posterior pillar. You have one pillar. Is not a problem. You remove the mucosa and you have to use the suture around this new pillar. Is not a problem.
Okay. Dr. Vikram Oberoi from New Delhi. Can palatal surgeries in general, and especially BARB, can it be done in grade 3 and grade tonsillar hypertrophy? So Srinivas and Filippo, I think it is the best case. You remove the tonsils and then you have all the more space.
Absolutely. Right? Like I said, one of the principles of reconstructive palatoplasty now is mucosa preservation, lymphoid excision.
Fine. Dr. Eva from Poland. Thank you, Filippo, for your wonderful and very educative presentation.
Thank you.
I have done some cases and have two questions. Did it happen to you that the sutures did come out?
Yeah.
And what is the protocol to take care of the pain post-operatively? So
pain,
what about first the sutures? Did they ever come out? And then what did you do?
Especially at the beginning, when you are a rookie, it's easier to have extrusion of the suture. If you have, always happen to everybody at the beginning. You have just to cut the suture that is outside the mucosa, close to the mucosa is not a problem. At the beginning, we used Stratafix. Stratafix was more rigid, and it was like a bone fish in the mouth of the patient, so it's painful. You have to cut as soon as possible this suture. The new suture are more flexible, are less painful, so the problem is less, but you have to cut the suture. Of course.
When you cut the suture, then what happens if it is happening within say 2 weeks? Then what happens to the surgery? Does it does the surgery fail in case the sutures come out?
If you cut just a small amount of suture, is not a problem, because in the conventional suture, let's say that if you leave the knot if you lose the knot of the suture in a conventional suture, you are lost because the knot is the main, let's say, holding of the suture. But along the barb, you have many spikes, many barbs. So even if you remove one piece of suture, it's not a problem. Of course, if you remove 10 centimeters of suture, you have a problem.
Yes, I think that's the most important thing to understand, the difference between barbed and routine sutures, that there you depend on one knot. The knot is gone, everything is gone. Here, everything is divided into so many small spikes.
Yes.
So even
Yes.
if a part of it goes, rest.
Yeah.
Okay, now the question being asked by many people about post-operative pain, foreign body sensation. This has also been asked by Dr. Jaimin Patel from Ahmedabad, Dr. Pooja Soyal from Haldwani in India, and Dr. Vijay Bansod from Maharashtra. So I think, Srinivas, can you elaborate on pain management?
So I think it's again very important that we speak about mucosa preservation again. So if you preserve mucosa and don't cut muscle, the pain scores generally will not be very high. And also when you tie the knots, if I'm just talking about regular sutures, I'm not talking about barb. When you tie the knots, the knot also should not be very tight on the mucosa, because if you tie the knot very hard, there will be avascularity of the mucosa, and the mucosa will just fall apart, and the muscle below will get exposed, and the pain will be very high. So what we basically have to be very careful with is when you take care of the mucosa, when you take care of the procedure by preserving the mucosa as much as possible, be gentle when you do the procedures. I think the pain score will be very less, and that's where I think all the newer reconstructive palatoplasties score. Post-operatively, I think the pharynx and the oropharynx is very sensitive. Pain will be there, whether it is tonsillectomy or, but the pain scores now with the newer reconstructive palatoplasties are far less than earlier.
Sima, would you like to add anything on that?
Just to answer to those people who are asking about the pain management, I think, why would it be any different from any tonsillectomy surgery? So eventually, what Srinivas just spoke about are the surgical ways to try to reduce as much of scarring and pain as possible. But there's also a patient factor where tolerance levels to patient would be different. And ultimately, in short, if I have to just say, all pain management should be just as any other tonsillectomy surgery. There should be no difference because we are doing barbed or we are doing reconstruction or whatever.
Filippo, you have anything to add, or this is good enough?
No, I agree. I agree. When you perform tonsillectomy, is always the same problem. Probably using coblation, I don't have a big experience by using coblation, but I think and I feel that by using coblation, the pain is inferior, but is not zero. But I suggest to everybody to perform always tonsillectomy. If the patient has tonsils, before performing a pharyngoplasty, you have to perform tonsillectomy, because some colleagues don't perform tonsillectomy, and they perform some kind of pharyngoplasty without performing tonsillectomy. It's not so common, but in some colleagues do this practice, and it's not correct in my opinion. You have to always to perform tonsillectomy, even if you can have post-operative bleeding and much more pain, of course.
So I would like to add few things, that pain in the oral cavity surgery is because of two factors. One is the mucosal loss. Just like if you have an aphthous ulcer, you'll have mucosal pain. So when you violate the mucosa, there's pain. This pain is like a burning sensation, as a constant pain. So if you give the patient post-operative lidocaine gargles or tablets to suck, that pain remains under control. The second pain is because of cutting of muscles or suturing of muscles. In palatal surgeries, we are always, changing the directions of the muscles. So if the muscles are inflamed, anti-inflammatory like NSAIDs will work. So reduce the inflammation to the minimum and give good anti-inflammatory, the pain will be under control. But if you have sutured the muscle to a different place and the muscle is still free to function, that pain is like the muscle is trying to pull, but there is a suture which is not letting it pull. So no painkiller will be able to control it. Therefore, Filippo showed that you release the palatopharyngeus in the lower part. Srinivas shows that you cut the muscle and you take it in that direction so that you do not force the muscle to work against a suture. So these are the things that are very, very important to remember. Now there's a question from Dr. Perla from Mexico. Hi, Filippo, excellent talk. I would like to know what you do if one of the sides of the pharyngoplasty gets a loose suture and how we can prevent it. You have partly answered, but if one side of the pharyngoplasty has a loose suture and it's already falling, then what can we do?
Good question. I have a couple of patients where it happened. You have to wait. You have to perform after 6 months the sleep study, and you have to see if the result is good or not. If the result is good, is not a problem. You can leave the patient with, let's say, half side done and outside not done. But if the result is not good, you have to evaluate the patient again. And probably if the problem is in the soft palate, you have to suggest another procedure, another palatal procedure. It's possible. After BARD, you can perform another time the procedure because the suture is absorbable. You can perform again BARD. It depends if the patient accepts to perform another surgery.
So the same question was asked by our own friend Dr. Sanjay Udupi from Chennai. One is that what will you do if the sutures are exposed after a month of surgery? You have already answered that if it is a small exposure, you'll cut and remove that part. And
Yeah.
what if it is completely out? And the thing you have answered this question as well. The next question is from Dr. Prakash Munka from Bokaro Steel City. Then he has also asked the same question: can barbed wire be repeated if, say, after 1 month there is some laxity and can be tightened further? Can it be tightened? I don't think there is a way to tighten it, or is it?
If you in local anesthesia, it's difficult.
Yeah.
So I suggest you to wait because sometimes even after tonsillectomy, you have a retraction of the posterior pillar. So it's always a good idea. It's always wise to wait at least 6 months, maybe 1 year, to do something else.
Correct.
Because maybe after 1 year you are lucky, and the nature work for you. You have to wait.
There's a question from Dr. Pooja again from Haldwani. When you use a single needle suture, do you still start from the midline?
Absolutely.
So you said that you'll start and go on to one side and then use another suture to come from the other side.
You connect the two suture and you create a long suture with 2 needles.
Yeah, but if you're using a single needle suture, then you use 2 sutures, one for the right side and one for the left side. So
Yeah.
that's the answer, Dr. Pooja.
Yeah.
Then there's a question from again Dr. Munka. I think what is the availability of suture in India, brand and price, alternate suture as about Prolene? I think it's available. You have already shown the Covidian. I am using that, Filippo, and it's available for I think 2,500 rupees. This is the answer to all my Indian delegates. 2,500 approximately is the cost of the suture. It's available from Covidian in India. And Dr. Munka is saying, can we use Prolene? So, Filippo, your take. Can we use Prolene suture? I don't think so because it will not work in one direction.
Yeah.
But can they take it? Can they come back and suture it? Use it? Your take. I don't think it can be done.
Prolene will not have the barbs also.
Correct. Okay. So now there's a question from Dr. Dharmesh Yadav Rao from Resort and Dr. Sampurna Ghosh. Srinivas, you take this question. So, respected sir, good morning, everyone. Authority over panel, so and so, very nice. can you explain the multidisciplinary approach, the sequential approach? I think it's a very long question, but in just 2 to 3 lines, if you can tell Srinivas, how do you approach the patient? What do you do just for?
Yeah, so basically it has to be a team approach. Even though the patient would have come to you or a pulmonologist, I think if it's a surgically correctable patient, you need to have your basic principles right. You need to know if it's a skeletal patient or a soft tissue patient, and try to see if there are any static obstructions. You remove the static obstructions and perform sleep endoscopy and take it from there. If it's a skeletal patient, go ahead, do any kind of a skeletal procedure. If obesity seems to be the problem, you need to definitely take a consult from your from a bariatric colleague. Lifestyle modifications are also very important, and post-surgery myofunctional therapy is gaining a lot of importance, and that also has to be advised.
And there's a question for Dr. Simab Sheikh from Dr. Eva from Poland. I usually do RF inferior turbinate, soft palate, and base of tongue as an office procedure at the same time, mostly for primary snoring and mild OSA. I always remove the mucosa of the uvula if needed as well during the same procedure. Do you also do that, Simab?
Well, Eva, I've never done all three in one sitting. So I wouldn't really, I mean, it all depends on different setups to setups. But doing three in one sitting on an OPD procedure, I've seen people in Norway also do that. Even Vikas knows that these guys do it as OPD procedures. I wouldn't advocate all three together, especially tongue-based RF with the others.
Yeah, so Dr. Magne also does not do RF tongue base at the same sitting. Second question she's asking you is if ulceration of the soft palate happens post-operatively, how do you treat?
Sorry. If the
Ulceration of the soft palate happens post-operatively, how do you treat?
really nothing. You just wait and watch. You do everything like you do for an aphthous ulcer. You just give them the little, like Vikas said, the lozenges, the lidocaine gargles, and you just wait for it to watch and make sure that it doesn't get infected. So if there's infection, then you probably need to clean that area again and start with higher antibiotics.
So do you prescribe steroids after RF palatoplasty and RF base of tongue?
No. After RF base of tongue, yes, orally, but after RF palate, not yet. Not needed.
So she also said my patients usually need more painkillers than paracetamol for post-op pain.
Yeah, absolutely. I would agree with you because it's individual pain tolerance levels and what you really need to use. The bottom line is pain has got fantastic painkillers. Just use it and let not the patient be in pain.
Okay, so there's another question from Dr. Danish and Rabi. Can nasal septal correction be coupled with palatal surgery or it should be staged? So I think we have dealt it multiple times that if the base tongue is not large, you can very well do nasal septal correction with palatal surgeries. Dr. PVLN Murthy from Hyderabad. Yeah.
I'll just add to him, to Dr. Danish, that as long as you're not packing the nose, then you're just fine to go ahead and do whatever you need to on the palate. So if you're going to be packing the nose, just be a bit more careful.
Yeah, if you're packing the nose, the tongue does not have to be large. If the tongue is not large, you can very well pack the palate also. So Dr. Murthy is saying that yes, lidocaine chewable tablets relieve a lot of pain. Dr. Yogesh from Modi Nagar, is ice of any use post-operatively? Srinivas?
Yeah, I think, well, I've been in the US, they used to use that a lot. I think we give our patients, ice lollies to suck on. I think it's a good, yeah.
Yeah, question from Eva again for Srinivas. Do you perform pharyngoplasty with coblation of base of tongue as one-time procedure?
Yes, I do.
So, Eva, the answer is that yes, it can be done together as long as the nose is not to be blocked. You can do palate and base tongue very easily. And even if the nose has to be blocked and you are very well expert like Srinivas is, and you have a very good ICU backup, then you can possibly do everything at one time. But I would not suggest that one goes in for everything at one go, as everybody else on the panel is also agreeing. Dr. Yogesh Singhal from Modi Nagar. Filippo, any foreign body sensation because of sutures? See, foreign body sensation will be because of any palatal surgery.
Yes.
Because of sutures, do you think there will be any foreign body sensation?
No body sensation if you insert the suture in the muscle. If
Correct.
you run, if the suture run just below the mucosa, the patient can feel the suture.
And I believe that with the new suture that you have advised, and I am also using it, the earlier suture was very thick and there was still some question of sensation. With the new suture, there's no sensation.
And usually it's easier to find in our hospital V-lock Covidian
Yes.
suture because
Yes.
general surgeons or urologists are used to use this kind of suture.
Correct. So now there's a very interesting question. Few of the patients of post-op RF reported drastic improvement of pain with consumption of alcohol. Simab, for you, you're Dr. Yogesh from Modinagar.
I definitely don't have a prescription where I can prescribe
Fine.
them any alcohol, but we don't even ask them to do it in the first
I
place.
know. So see, we all have to have our opportunity to smile there for these questions. A question from Sahir from Trivandrum. For surgery, role of weight reduction, I think it's a no-brainer. Everybody has to be advised to reduce weight. And a question to you, Filippo, from my side. Why do you start from the junction of the hard palate and the soft palate, whereas the we have shown in our drug-induced sleep endoscopies that the real reason of the uvula, the base of the uvula is the reason where the soft palate goes and touches at the back. So in my technique, I go from one side of the pterygomandibular raphe to the other side of the pterygomandibular raphe, going across the line, passing through the base of the uvula. So one question is that why do you start from the top and why do not you start from the base of the uvula? First
So
of all.
we start from close to the hard palate because, as I showed you, there is an aponeurosis close to the hard palate that can fix the suture. For that reason, we like to start close to the hard palate. But as you told a few seconds ago, at the end of the procedure, we cross the soft palate by the suture from the left side to the right side in a horizontal line.
Yeah.
Because the problem, especially for snoring, is close to the free edge of the soft palate. So we have to stabilize that area close to the uvula. But
The paramedian plane.
yes, we used to go there at the end of the suture. Sorry, at the end of the procedure.
So that brings me to the second question I had for you, that you said that if the uvula is really large, you will not mind resecting a part of the uvula, but you'll not resect the complete uvula. See,
Yeah.
when the snoring is happening from the base of the uvula, and you are anyway giving pain to the patient by sacrificing half, why not remove it from the base? Because I do that, so we are discussing. I want to take your opinion.
You are right. You can remove even completely the uvula, but keep in mind you have to suture the mucosa not at the free edge of the soft palate. You have to suture the mucosa of the palate, let's say anteriorly. You have to leave more mucosa posteriorly, as Srinivas told us,
Correct.
because in this way there isn't a scar on the free edge of the soft palate, and the patient with the tongue cannot feel the scar.
Very nice. Yes, Sima, you wanted to say something?
No, I actually want to, excuse me. I actually want to ask a question to Filippo. Filippo, if I remember right, about 3 years back, 3 to 4 years back, when I picked up this technique from Professor Vicini, and you and Professor Vicini were doing, I remember very distinctly, we having this discussion, where you were doing research on the actual amount of pull that you want to give on the suture with the weight, and then decide as to what exact tension you want to give onto the suture so that it does not really pull so much of the muscle that the muscle will tear away or pull away. Has something further happened on that as yet? Because that at that time sounded to me so technical that I just gave up on that discussion.
Yeah, no, it's very difficult to measure the force that you use to pull up the suture. Anyway, by experience, you can understand to pull up the suture, but not so much. So I suggest you you pull up many times during after every step the suture. So when you perform a step, don't pull up too much the suture, because otherwise in the next step you will have too much tension. So it's difficult to explain, but every step you have to use not, you have to pull up not so much, but step by step. It takes sometimes to understand this concept, but you are right. If you pull too much the suture, at the end of the procedure, you will have too much tension.
So now there's a question from Dr. V. Shangumam from Namakkal and Dr. Jagan Mohan Reddy. Is there any chance for nasal regurgitation of fluids? Any chance of voice change? So Filippo, will you like to take that?
So
Voice change and
no,
regurgitation of, and
no.
why
So
so? Why so?
voice change, usually the voice change after a tonsillectomy if you have a very big tonsils. But when you perform palate surgery by using the new kind of pharyngoplasties, the voice doesn't change. It's not a big trouble. About BPI, velopharyngeal insufficiency, by using the new procedures is not a problem. In the past, when we used UPP and we removed too much in the central area of the soft palate, the problem of BPI insufficiency, velopharyngeal insufficiency, there was this problem if you remove too much in the central aspect of the soft palate. But even if you pull up in an important way the lateral aspect of the soft palate, it's very difficult to have velopharyngeal insufficiency.
So I would like to add up that unless you violate the levator palati and the tensor palati, you cannot get a velopharyngeal insufficiency.
Yes.
And secondly, if you do not create a lot of raw area on the free surface with cautery, which will cause a fibrotic scar to pull the whole soft palate down, you will not get a velopharyngeal insufficiency. Neither you will get a voice change. As Filippo said, that voice change will happen in large tonsils because the volume of the oral cavity has reduced. So there is a change in the resonance of the whole pharynx. So I think most of the questions we have been able to answer. And in the end of it, I believe I'll just like to sum up by stating what Simab had started with minimally invasive surgery. So I think his message was that the minimally invasive surgery on the soft palate is only for snoring and mild sleep apnea. Please do not try to do something because you cannot do anything else. You do something for a maximally, suffering patient with a severe sleep apnea, obese guy with a very thick palate. It will not work, right, Simab? You said that. And it is not very useful for the very thin palate because then you'll have risk of perforation. It's not very useful in the very thick palate because again you'll not get great results. And you always like to combine it with other procedures like RF of inferior turbinates and RF of base of tongues, though in different settings. Then Filippo showed his techniques excellently. I believe very nicely demonstrated barbed thing. You explained everything about the barbed suture, how they are good. And gradually the whole world, even a person like me who was earlier not using barbed suture, you have converted me to using a lot of barbed sutures. So barbed is the new in thing, and this will also provide possibly solutions for the problems like collapsible hypopharynx where nothing else can be done. Possibly later we can tighten the hypopharynx also with the barbed put inside. So it has a lot of promise, and barbed is going to, it's free of major complications. And then Srinivas actually detailed on the philosophy of different types of palatal surgery and the basis on which you can do different types of palatal surgery. So Srinivas explained that what kind of palatal surgery should be done in what kind of procedure. And we have been able to take almost all the questions, all the important questions. There are some repetitions and there are a lot of congratulations, so I'm not going to take them. And thanks for the nice session. Is it okay? One last question from Dr. Vijay Choradia. Is there possibility of palate surgery without coblation? So I think yes.
Of course.
Okay, so Filippo, when you do barb suture, you remove the tonsils with what? Coblation, cautery,
No,
cold steel?
yeah, cautery. I don't have coblation, but I would like to have coblation, of course. You can do it. By coblation, probably it's less painful, and you have more experience than me.
I know. No, but you use cautery to remove the tonsils, right?
Yes, yes.
Srinivas, what do you use? You use everything: coblation, radio frequency, cautery, whatever is there.
No. I predominantly use coblation and radio frequency.
Coblation and radio frequency predominant. So that's the answer, Dr. Vijay. I think it's 12 o'clock sharp on the dot. If you like to add anything, all the panelists, any take-home messages from your side? Otherwise, we'll call it a day.
I think you've beautifully summed it up, Vikas. I think thank you very much. Thank you, Filippo. Thank you, Seema.
Welcome.
Yeah.
Filippo, good morning. Have a great day ahead, please, and stay.
Mr. Sahai, can you? Mr. Amrish Sahai,
Yeah.
can you join in?
Yes.
So I, as a moderator of this
Before
session,
we forget, because remind them about the Sunday schedule, which is having a 6 p.m.
Why didn't you announce it, Sagar?
Yeah, you want me to do it? Yeah.
Yes, please.
Yeah. So, audience, it is very nice having you all in this OSA classroom.
Let us see your face also, Sagar, please.
Yeah, I think
Start your, you start. You start.
Yeah.
You start now.
Yeah. So I thank you all for your wonderful participation. More than 1,000 delegates have been there all over the world. For the change, the next coming series is going to be on Sunday. That is on 10/5/2020. It's going to be on Sunday. We are going to be dealing with all pediatric OSA topics. I think Dr. Vijaya Krishnan, Dr. Srinivas Kishore, Dr. Roshan, pediatric dentist, will be giving the talks. And I think it will be moderated by Seema Sheikh. So I would like all the audience to log in on this Sunday, that is the 10th. And the time is going to be 6 o'clock in the evening. 6 o'clock in the evening, please note it down. It's not 10 in the morning. It is again 6 in the evening. Once again, thank you all for doing a fantastic job. We really were mesmerized for the past 2 hours, and it was a great moderation as well. Thank you.
So I hand it over to Mr. Amrish Sahaya from Sun Pharma, and once again we thank Sun Pharma to support this very nice cause.
Thank you very much, Dr. Agrawal. While we conclude today's series 5th of our webinar, let me convey my heartiest thanks to all our eminent speakers, very especially Dr. Seema Sheikh, Dr. Filippos, and Dr. Srinivas Kishore for making the sessions so interesting, informative, and of course, so simple. So thanks a lot, Dr. Vikas Agarwal, for beautifully moderating the session. And we are indeed thankful for the immense contribution for beautifully organizing the topics and scientific contents. Dr. Vijaya Krishnan, Dr. Vidyasagar, Dr. Naveen Patel sir, and Dr. Divangar. Indeed thankful to our delegates for sparing your valuable time this morning. And we are indeed thankful to our digital team for making the flawless audio video. So we from Sun Pharma, actually 38 divisions. It's the Pharmacare division of Sun Pharma, which is actually the face of the 8. So on behalf of Pharmacare division of Sun Pharma, we thank each one of you.
Thank you.
So with this, we conclude our
Thank you.
Thank you.